Very good morning to all of you and welcome to the GMO Academic Program. So today's topic is basics of clinical transfusion practices. Today we have invited Dr. Samantha Senavirathna, who is the consultant transfusion physician attached to Teaching Hospital Kurunegala. Dr. Samantha Senavirathna was graduated from Faculty of Medicine, University of Peradeniya in year 2011 and joined the National Blood Transfusion Service of Sri Lanka in 2015 as a medical officer. So he has completed the postgraduate diploma in transfusion medicine in year 2016 and completed his MD in transfusion medicine in 2018. He has obtained an MSc in biostatistics from University of Peradeniya in 2020, and further he has obtained an MA in Buddhist Studies and MA in Buddhist Ayurvedic Counseling from the Postgraduate Institute of Pali and Buddhist Studies in Sri Lanka. So Dr. Samantha Senavirathna is a co-secretary currently for Sri Lanka College of Transfusion Physicians, and he also is a member of International Society of Blood Transfusion and American Association of Blood Banks. So in addition to his academic career, he is a poet and a recorded lyricist. So let's warmly welcome Dr. Samantha Senavirathna to today's program. If you have any questions related to blood transfusion, clinical transfusion practices, please send them over through the chat box. We can attend to those questions at the end of the lecture. So let's listen to Dr. Samantha.
Good morning to you all. Thank you, Dr. Charuni, for the kind introduction. As well as thank you, GMOA Academic Committee, for giving this opportunity to talk us on an important clinical area, which is important for all the medical officers who are working at the wards. So we will move on to the lecture topic. Today our topic is basics of clinical transfusion practice. In this topic I will discuss about the important transfusion aspects that are currently practiced at the wards. That means bedside transfusion practice. So our objective is to understand the understand the basics of decision in the making the transfusion, and some aspects of consent, and how to, more importantly, how to take the pre-transfusion sampling, and including prescription, and picking up the blood when the patient is ready to be transfused, and administration at the final check and the administration, and plus the monitoring of the patient throughout the transfusion, and finally the identification and management of transfusion reactions. That means the management of adverse events of the blood transfusion. So to give a brief introduction about blood transfusion system in the Sri Lanka, it is coordinated by the National Blood Transfusion Service of Sri Lanka. It is a centrally coordinated system, so that means that the island-wide the service and the quality of the blood component and the services provided are same and equal. We give equal service to every blood bank. There are around 100 blood banks in the country attached to the hospital. So there is no difference between the quality of the blood products. So that's why the central coordinated system or the central coordinated blood service play an important role. It comes under the Ministry of Health, under the laboratory service. It was established in 1960s, and it is the main supplier of blood and blood products to all the government hospitals plus majority of private sector hospitals. So our responsibility as NBTS is to ensure the safe blood transfusion to all the patients who need blood components. So One word about our blood donors. Since 2014, we have declared that we accept only blood from non-remunerated donors. In several decades back, we have heard that we take that replacement donors. That means that if a patient needs a blood unit, the patient has the responsibility to get down a donor to the blood bank. So that burden is no more there to the donor. We have taken that burden to our hand to improve the quality and the safety of the blood unit that we issue, so that we can take blood safely from the donors, and we do screening procedure for each and every donor. So every person is not suitable for blood donation. The donor must be safe to donate in terms of the safety of the donor as well as the recipient who receives the blood, the patient. So that if the donor is having any risk factor to have a disease that can be transmitted via blood, those donors are not accepted. So that's an important aspect of the voluntary non-remunerated blood donation. And after recruiting as donors, the donors undergo a confidential counseling session by a trained medical officer, and he signs the declaration form that the provided facts are true and correct. The blood components that are available in our blood banks, mainly we don't use whole blood anymore. We use blood components or blood products which are made from whole blood. Basically there are two parts, cellular products and plasma products. Main cellular products are red cells, platelets and white cells, which is called Buffy coats. Plasma products are mainly fresh frozen plasma, commonly known as FFP, and we produce cryoprecipitate and cryopoor plasma as well. So those are the basic blood products that are available at our blood banks. Plus there are some modified products. For example, red cells may be leukoreduced or leukodepleted, and there are washed red cells and plasma reduced platelets, irradiated blood products like red cells and platelets. Likewise, there are special products. However, these are the basic blood products that are available at our blood bank. It is important to know that every blood donation is screened in Sri Lanka for 5 main diseases: hepatitis B and C, HIV 1 and 2, plus syphilis and malaria parasite through the blood film. So we do those every screening test with highest standards accepted by the WHO. For example, for HIV 1 and 2 and hepatitis C, we do both antigen and antibody testing, which is called combo test, to ensure the minimum window period in blood donation. For hepatitis B, we do hepatitis B surface antigen, and for syphilis, the screening test is VDRL. And for malaria, we do the blood film testing, which is considered as the gold standard for malaria parasite. So we'll move on to our topic, safe transfusion. How can a ward, a medical officer who is working at a ward can contribute to the transfusion practice safely? So the first thing is the decision making. It is very, very important, because that decision makes patient's life a lot. So when the decision is making on blood transfusion, as for any treatment modality, we have to consider the patient's clinical condition together with the laboratory parameters, and it should be individualized, and only if the advantages of transfusion overweighs the risk or harmful effects, only we have to go ahead with the transfusion. Even in the even if we have made the decision to go ahead with transfusion, we have to select correct blood component, especially the correct dose. If one blood unit is enough for one patient, it is enough. We don't need to give 2 units when the patient needs only one pint. And we have to consider the patient's special requirements as well. We'll see what are those requirements, and the patient should be involved in the decision in that decision making. So we have to explain the risks and the benefits, and we have to provide the information about the alternatives for transfusion as well. So the patient's decision is patient's choice should be there. So that is another important step in blood transfusion, informed consent. So as I mentioned earlier, in the decision making, the patient must be involved. A clear explanation should be provided, and we have to explain about the common and rare risks, but rare risk may be serious or even fatal, so we have to provide those information to the patient, and we have to explain about the alternatives, and the patient must be provided an opportunity to ask questions and clarify doubts about this transfusion process. And we have to document that consent in our legal document is the BHD, so we have to mention it in our BHD. Currently we don't have a proper consent form for transfusion. We are in the process of introduction of such a form or a consent form, so we can fill that easily and get the consent. So this is the proposed one, so we have to explain and to the patient and get the consent, informed written consent from the patient. This can be the patient or the guardian if the patient is below 16 years of age. So when we are filling the pre-transfusion form or the blood request form, we have to consider the important factors when we fill. I think almost every medical officer, because they have completed the internship, they have completed this form during their lifetime, so they are very familiar with that form. However, still at the blood bank we find some mistakes or some missing information when we receive those request form. So at the top we have to categorize the blood request as a routine, urgent and emergency. So depending on the hospital, as discussed, they have identified a time limit to accept routine cross matches. It most probably it may be 11 a.m. or 10 a.m. However, forgetting or missing such cross match is a mistake, does not make that transfusion urgent. So we should not make it urgent and send to the blood bank. Rather, you can discuss with the blood bank and send it in a friendly manner. And you have to mention the indication for transfusion, and more importantly, an indication must include if it is a red cell, it must include the hemoglobin level, because we have to prioritize the blood products at our blood bank. And importantly, the past transfusion history, because some compatibility testing needs past transfusion history, and for modification of blood products like washing, we need that information. And all the clinical details such as primary diagnosis, comorbidities and relevant medication history is important in some testing. Those medications could affect our testing procedures. And if the blood group is available, it should be mentioned in the blood request form. It must be with a documented evidence. Documented means it does not include any departmental identity cards or the driving license. It must be a diagnosis card or a clinic book which is issued from the health sector, not from the other departments. So if it is available, it is important to mention it, because if it is not, if the documented blood group is not available, we have to do the blood group twice. It takes our time, human resources, as well as the costly reagents we have to waste. So if the blood group is there, please do mention that. And hematological parameters like hemoglobin level and platelet count in case of platelet transfusion. And if the blood is needed for a surgery, you have to mention the date and the time of the planned surgery. And in females, current or recent pregnancies are important, because same as transfusion, they can through pregnancy there is sensitization to other red cells, and red cell antibody formations do occur. And if there is any past transfusion history, you have to mention it. And special requirements or the modifications of blood products, and importantly the dose must be correctly mentioned. So in terms of dose, it can be divided as adults and children. For adults, we usually go by units. For example, for red cells, you can request 1 unit or 2 units, but always give 1 unit, and after that please reassess the patient before giving the second unit. And from that you can avoid many transfusion reactions, and we can prioritize our resources, blood products for the needy patients. And platelets, the usual dose is 1 adult dose. It is called 1 adult dose. However, it contains 5 to 6 random donor platelet. That may be different when the apheresis platelets are available. So if apheresis platelets are available, we can give in 1 bag. However, when the platelets are made from whole blood, the 5 to 6 units are needed to make 1 adult dose. However, there is no much difference between a therapeutic effect between the random donor or platelets and apheresis platelets. For FFP, the usual dose is 4 units, and cryoprecipitate 1 adult dose means 10 units. That means we have to pool 10 individual units and thaw it and dilute it in normal saline and give. For children, the dose is very, very important. Usually red cells are given in a dose of 10 to 15 milliliters per kilogram. Platelets, similarly, we can give 10 to 20 milliliters per kilogram. However, the maximum dose must be 1 adult dose. And for FFP, we can give again 10 to 15 ml per kg, and cryoprecipitate is 1 unit per 5 kilograms of body weight. That means if the child weighs 10 kilograms, we have to give 2 units likewise. Special requirements of blood products. Leukoreduced blood is given to the transfusion dependent patients like thalassemics and sickle cell disease. And especially in Sri Lanka, leukoreduced blood are given to the patients who are awaiting renal transplants, the patients with CKD, because reduction reduces the making of HLA antibodies, which is important in histocompatibility in renal transplant. Washed red cells are given patients who has shown severe allergic reactions, especially again thalassemics. And irradiated blood products are needed depending on the diagnosis, and some drugs like ATG, they need blood products, otherwise they can develop a serious transfusion hazard, which is called a transfusion associated graft versus host disease. So it is a fatal condition, so that we can avoid that by irradiation blood products. However, only cellular products are irradiated, like red cells and platelets and buffy coats. Plasma products like FFP, cryoprecipitate or cryosupernant, we don't have to irradiate. Unfortunately, we have only one irradiator available in Sri Lanka, which is they are in the National Cancer Institute. So if your blood bank needs irradiated blood products, we have to get it down from Maharagama. So we have to send it to Maharagama to get irradiated and get it down back to the blood bank and issue. So it takes times, maybe hours or even 1 to 2 days we have to wait, depending on the location of your hospital. So sometimes we give plasma reduced platelets to patients who are allergic to plasma proteins, and for children, if we need to give much high dose of platelets, we can give plasma reduced platelets. HLA matched platelets are given to the patients who shows platelet refractoriness. That means there is no increment even given platelets repeatedly, so that we have to match them and importantly, when the platelets are HLA matched, we have to irradiate it again, so that it takes time as well. So when you are sending the sample, pre-transfusion sample or pre-transfusion specimen to the blood bank, it is important to know there is an expiry time. So if you are sending the blood sample today, it can be valid up to 3 months. However, we have to know there are some limitations of that. If the patient is currently being transfused or transfused within last 3 months, or if the patient has been pregnant within last 3 months, there is a risk of making additional antibodies, so that sample valid only for 72 hours. If the patient is not pregnant or not transfused within past 3 months, we can keep them up to 7 days. So in Sri Lanka, the practically maximum shelf life of that specimen is 7 days. However, if we keep it thawed, we can go up to 3 months, but it's not practiced in Sri Lanka. So if the patient has no transfusion or pregnancy within 3 months, we can if there is no history, we can go up to 7 days. If there is a history of transfusion or pregnancy within last 3 months, the maximum is 72 hours. That is the accepted sample validity in Sri Lanka currently. So we'll talk about pre-transfusion specimen collection. So this is mainly done by nurses, but as medical officers, we have to know the procedure and we have to supervise them. Plus in emergencies and mainly in ETU or mainly in emergency department or in the theatre, medical officers also have to collect the sample and send it to the blood bank. So we have to know the correct procedure about that pre-transfusion specimen collection. So importantly, after filling the request form, sampling and labeling can be done, and it should be done as a one continuous uninterrupted event. So we should not engage in other works when we are collecting sample for pre-transfusion testing. And always we have to take precautions not to take blood sample into a pre-labeled tube, so it can lead to mistake. So that we should take the sample, then after only we have to label it at the patient's bedside. Always we have to ensure the positive patient identification. We'll explain that later. That means we have to get the patients, we have to correctly identify the patient that with the correct request form. A second sample is needed when the historical or the documented blood group is not available. This is to avoid ABO incompatibility due to mistakes. So, yeah, however, we have to keep it in mind that we should not take the both samples together. So, it should be two independent process. So about positive patient identification, which is the critical step in sample taking as well as in the final blood administration. So always the details on the request form must be correct and identical with the specimen, and it should be matched with the patient. The principle of identifying your patient are always the same. There are three identifiers that must be matched. It should be full name, not a part of a name. For example, there may be several Senavirathnas in the ward. So if we call Senavirathna, one would come. So we have to go by the full name. It is both family name and given names or name with initials. And importantly, we have to ask for the date of birth, but in Sri Lanka we practice it as age. However, we have to ask the full name and the date of birth or the age, and the bedhead ticket number, which is unique for the admission for the patient in a particular admission. It should be matched with the request form and the sample and the patient's BST. And in private hospitals, they use a wristband, which is very important and critical in such a positive patient identification. Unfortunately, we don't have that facility in government hospital. However, when it is needed, especially in operating theatres, there are the instances they have. So we can identify the patient when the patient is anesthetized. We can go by with that wristband. So always we have to check for all those details in the documents. So in special considerations, in conscious and rational patients, we can when we take the sample, we can ask the patient to state and spell their full names. Like ඔයාගේ නම කියන්න. Don't ask the name like ඔයා Senavirathna නේද? That our patients are very happy to say yes. They don't like to say no. So they will say yes. So don't give the name to the patient. Ask them to state and spell it. But if the patient is unable to identify, we have to go by basically the identification band. Sometimes a family member may be present, or sometimes interpreter may be required. Emergency situations like in disasters, so sometimes the names are not known, so there is a hospital unique number for disaster. We can go by with that number. However, when the name is available, we have to switch to the name rather than the number. And when the electronic patient identifications or the records are available, now many of our hospitals are moving for electronic records and computerization. However, it does not replace the positive patient identification. The only difference is we are replacing the BST with an electronic record. However, we have to go to the patient and ask the name and the other details. So again, another important step is specimen labeling. We have to label the specimen only after collecting the blood into the tube. Blood should be collected to an unlabeled specimen container, and the patient identification details must be added immediately after blood is collected into the tube at the patient's bedside, not at the doctor's counter or the nursing counter. we have to mention the date and the time of the collection, and we have to write it in on the label, and the collector should sign the label as well as the request form as the phlebotomist. And when this specimen can be rejected if there is any discrepancy. So there are the sample must be discarded if there is any discrepancy to avoid sample mixing up. So we have provided from the blood bank, we have provided the specimen label. So here they are not used. So this is not acceptable as blood bank sample for pre-transfusion testing. So we can't accept such samples for our testing. So this is the correct way. We have provided those blood bank specimen. Those are stickers, so it's very easy to use. So you can write the details and paste it on the test tube, and you have to put your sign and the date there, and all the details are there. So there you won't miss anything if you go by with this label. Again, when you are picking up blood as well, you have to when you are sending someone to collect blood after cross matching, you have to correctly identify the patient, and patient's full name, date of birth and medical record should be available, and what is the blood product required should be clearly mentioned, because some patients need several blood components. They may need red cells as well as platelets. So you have to mention the correct one which you want to give first to the patient. So at the blood bank we'll explain briefly what we do in the blood bank. In our pre-transfusion testing laboratory, we do ABU and RHD grouping. That is, we group the blood group as B positive or O negative likewise. And we do an antibody screening. So we check whether there are red cell alloantibodies in the plasma against the red cells. So finally there is a compatibility test which is included in our final test. So we check whether the donor blood is compatible with the patient. So what we do here is we mix donor's red cells with patient's plasma and see whether there is a reaction. So that is important to identify any mismatch between the donor and the recipient. Sometimes there may be patients who have developed antibodies, so that if there is any red cell antibody, we have to give antigen negative blood, that the corresponding antigen should be negative in the donor blood. So we have to select those antigen negative blood. It may take several days even to select such blood if that blood is rare. So when you picking up blood, before picking up, please make sure that an IV line or the IV cannula is working and it is available. So don't get down the blood pack and then try to insert the cannula, because if you fail, the blood packet may be in the out of temperature control for hours. So sometimes you may have even to send the patient to the theater even to access the veins. So what you have to do is get a proper venous access only, then after only you can request the blood product to the ward. The written details of the patient and the blood product should be provided, and you can hand over the form, the request form and the bed date ticket to the blood bank issue counter, and please inform the person who takes blood to check whether it is you have collected the correct one. Just see whether it is red cells or platelet. So transporting blood. This is a very important area, but most of the time it's missed. I mean, they do not care about protection or the safety during transportation. So mainly our blood, commonly it is transported by minor staff, so they do not take any responsibility. So that they can collect the blood pack and go to the canteen and to the bank or the ATM and go to the overseer's office and sign, or whatever they want they will do. So what you have to do is you have to instruct them clearly. After collecting the blood, they have to come as soon as possible to the ward. So because we can't keep the blood products out of control for many time. So for red cells, we have to start it after taking from the fridge. We have to start the transfusion within 30 minutes. So it's a very limited time. So ask them to come directly to the ward. And rough handling of the products may cause physical damage, and we should not keep them in hot temperatures. And even after getting to the ward, do not keep it in the outdoor temperatures, or if the transfusion is delayed, do not keep it in domestic fridges which are available in ward. So it should be kept only in blood bank refrigerators. So never leave it unattended, and there should be accidental transfusion. So finally we have to prepare for the administration, and again we have to check whether the prescription is complete and informed consent is obtained, and we have to identify we are giving the correct component, and then we have to explain the procedure or about blood transfusion to the patient in a simple manner. And we have to give a brief explanation about the transfusion reactions or the unwanted effects and the symptoms of them, and they must be encouraged to complain any symptoms that they experience. And always baseline parameters must be recorded, and it should be mentioned in the BHT, especially about temperature, pulse rate, blood pressure, and saturation. And if there is any pre-existing rash, you have to mention it, and the general status. And always that the situation must be ready to start the transfusion, and staff should be adequately available, and always try to avoid unnecessary transfusion at night, because that the staff availability and the facilities are not that ideal to manage a transfusion reaction. And always patient resuscitation facilities must be available, and all the things must be in working manner, like oxygen cylinder and adrenaline. All those things must be available. The final check, this is the critical step that where medical officer plays an important role, and this is the final opportunity to prevent any erroneous blood transfusion. So that we have to be more cautious about this step, and this must be done at the patient's bedside. It is not in the doctor's counter or the clerking table, not at the doctor's canteen or the HO's quarters. So you can't ask the minor staff to take the blood back there and check at the canteen. So it must be done at the patient's bedside. Again, you have to check for the patient's positive patient identification. As I mentioned earlier, patient's full name, age, and the BHD number should be matched with the all the labels, like the compatibility label, which is called blue chit commonly, and the pink chit, that is the compatibility report is the blue chit, and the compatibility label which is known as pink chit, and there is a number or the DIN number in the blood pack, and it is mentioned in the patient's BHT on a rubber stamp. So all those things must be compatible, and if there is any discrepancy, please do not transfuse that and inform the blood bank as soon as possible, and you can return the blood pack to the blood bank if there is any discrepancy. Always before transfusion, always again I advise you to check everything, and after positive patient identification, check for the date of collection and the date of expiry, and check for any pack damages. If there is any pack damage, do not go ahead with the blood transfusion, and inform us and return the blood pack. And if there is any clump or abnormal clumps or discoloration, which is a sign of bacterial contamination of the blood products, they are not suitable for transfusion. Usually we also check before issuing to the wards. However, if there is any mistake, you can identify, so that please do not transfuse such blood packs, and please return them to us. There is something called double independent check-in. So when the check-in, the final administration checked by two staff members individually. They should not do it together, but it should be two individual processes. We don't mind whether it is two doctors, one doctor and one nursing officer. However, those things must be two independent checks, and both are both must be accountable for the accuracy, and both should be signed in the BHT that to ensure that this is there are no any clerical errors. So commencing the transfusion, all the things are correct, that means the visual examination, expiry date, and or if the positive patient identification is correct, we can mix the pack gently, but never shake very vigorously, and then we have to spike the blood pack with the issued blood administration set. So do not use the IV sets that are available in the ward for normal saline and other fluids. Use our blood administration set, which has a filter which removes clots and debris. So when you are given two red cell units, you can use the same blood administration set. However, if you are given another separate component, you have to use a new blood administration set. This is about the medications and IV fluids given together with blood. So we do not recommend you to give any other therapeutic fluid in the same venous line cannula. Only generally normal saline is only compatible, but you can give ABO compatible plasma and 5% albumin as well. However, we do not recommend you to give fluids together with blood, because if you contaminate blood with other fluids, even with distilled water, it can cause hemolysis. So never give medications like anticoagulant, additive solutions, or dextrose or anything together with blood products. So another important part in blood transfusion is monitoring the patients during transfusion. Ideally, you have to measure before transfusion. If the parameters are available within 1 hour, it's okay. Otherwise, you have to measure it and measure the parameters, document it, and start the transfusion. And after initiation the transfusion, you have to measure all the parameters 15 minutes after, because we have to recognize if there is any reaction is happen or not. And even after the end of even at the end of the transfusion, you have to monitor the every parameters and document. And more frequent observations are needed in rapid transfusions and if the patient's vitals are not that stable. Throughout the transfusion, patients must be regularly under visual observation, and patient must be advised to inform any unusual symptoms if there is anything. This is an example of a monitoring chart. You have to mention before transfusion, 15 minutes after, and at the end of the transfusion. Monitor the pulse rate, blood pressure, respiratory rate, oxygen saturation plus temperature. I haven't mentioned it here. However, that temperature is also important. And if the patient develops any transfusion reaction, stop the transfusion, and at the detection of that reaction also you have to mention everything and document it. So one word about administration duration. The rate of red cell transfusion will depend on the patient's blood volume, cardiac and hemodynamic status. If rapid transfusion is needed, blood can be given as rapidly if the patient's circulatory system will tolerate, like in massive bleeding. In non-urgent, non-bleeding setting, each unit is usually infused over 1 to 3 hours in adults, but always it should be completed within 4 hours. A slower rate should be considered in patients with circulatory overload. However, the maximum time allowed is 4 hours. So when the blood unit is removed from the blood bank fluid, the transfusion should be started within 30 minutes and it must be completed within 4 hours. For other blood components, platelets must be given 15 to 30 minutes per unit, fresh frozen plasma 30 minutes per unit, and cryoprecipitate again 30 to 60 minutes per adult dose. So if you do not use blood components, please return them as soon as possible, because that is a scarce resource and we can use them for another patient. So if you are not using the blood product, send them as soon as possible, and if it is within 30 minutes, we can use for another patient. We can cross match directly for another patient if you return it within 30 minutes. However, we can consider and check and reissue to another patient if you return it within 1 hour. After 1 hour, we cannot use them, we have to discard them. So that is very expensive, so don't you do that. If you are not going to do the transfusion, please return them as soon as possible. So we'll move on to the last topic about transfusion reaction. Transfusion reaction means any adverse event that can be happen due to the blood transfusion. So any treatment modality like antibiotics, analgesics, or even surgeries, they have unwanted defects. Likewise, we also have unwanted defects after blood transfusion, so they are called transfusion reactions. Depending on the chronological order, they are divided into acute and delayed. Acute does not necessarily mean that happens during the transfusion. Acute means within transfusion or within 24 hours of transfusion. So on the same day, if the patient develops any transfusion reaction within the same day after transfusion, we call it acute transfusion reactions. Delayed transfusion reactions are reactions that appear after 24 hours. Depending on the pathophysiology, they are again categorized into both of those. Acute and delayed are categorized into immunologic and non-immunologic. Acute immunologic reactions are hemolytic reaction, febrile non-hemolytic reactions, allergics, and TRALI. TRALI is transfusion related acute lung. Among them, most dangerous one is the acute hemolytic transfusion reactions, which occurs mainly due to giving wrong blood to a wrong patient, that is due to ABO incompatibility. Non-immunologic acute reactions are bacterial contamination, that bacteria can go with blood pack and cause sepsis in the patient, and circulatory overload, and physical and chemical hemolysis. For example, if you squeeze a blood pack through a narrow cannula, it can cause physical damage to red cells, and it is called physical hemolysis. If you contaminate any drug or any other fluid, and it can cause hemolysis of blood, that is called chemical hemolysis. Likewise, there are other methods of hemolysis apart from immunologic hemolysis. So delayed immunologic reactions are delayed hemolytic transfusion reactions, which can happen due to unexpected or minor blood group antibodies. Transfusion associated graft versus host disease, which is rare but can be fatal, so that's why we irradiate blood products for needy patients. And post-transfusion purpura is something associated with low platelet counts occurring after 5 to 7 days after blood transfusion. Non-immunologic delayed reactions are transfusion-induced hemosiderosis, that is iron overload, which is common in transfusion-dependent patients like thalassemics. And disease transmission is transfusion transmitted infections like HIV, hepatitis B. Even though we check for all those diseases with sophisticated investigations, the viruses can pass because of the window period. So that's why the donor screening through the counseling is important. However, if the donor does not give the correct information, and if the donation is in the window period, we cannot catch them, and there is a risk of being disease transmitted. So it is important to recognize the transfusion reactions and manage properly. Importantly, that initial treatment of acute transfusion reaction is not depend on the diagnosis. Rather, it must be directed against symptoms and signs. So we have to manage the patient symptomatically, and treatment should not be delayed until we make a proper diagnosis. It is important to know that signs and symptoms are not specific for each reaction as well, and more than one reaction can occur simultaneously. Plus, there can be patients' comorbid conditions or primary diagnosis can mimic or alter the classical features of a transfusion reaction. So, when there is a transfusion reaction, or when we suspect a transfusion reaction, first thing as the ward medical officer is what we have to do is stop the transfusion immediately and disconnect the patient from the blood pack. If the patient develops any chest pain, fever, or pain along the transfusion site, or any abdominal pain or any discomfort, we have to think about the transfusion reaction and stop it, and please remove the line, otherwise the one nurse will come and start it again. So don't leave it here, stop the transfusion and disconnect from the blood pack, and always then you have to give a normal saline drip to keep that IV line patent. Otherwise, if the patient is going to collapse, you won't be able to cannulate the patient again. So that is important to maintain the IV access and assess airway breathing and circulation, and perform a bedside clerical check. That means you have to check the positive patient identification again, because this may be a wrong blood for another patient. So if there is any discrepancy, don't hide it. Inform the blood bank immediately, because even if the blood bank has done the mistake, there is another patient maybe at another ward may be in danger. So we can avoid that reaction in another patient if you informed us as soon as possible. Even the mistake is from your side, please inform us to avoid those things recurring. And examine the blood pack for clumps and discoloration, and continuously monitor the patient and support the patient's clinical symptoms. So that's the basics of managing of a transfusion reaction. I didn't mention even about hydrocortisone and pyritin. However, if you go through our BHTs, almost in every blood transfusion they say if there is a transfusion reaction, stop the transfusion and give hydrocortisone and pyritin, which has become the Kokatattaile of transfusion reaction. Even for fever, they do not give even paracetamol. What they give is pyritin and hydrocortisone, which is really inappropriate. So that always go by the patient's clinical symptoms rather than giving hydrocortisone and pyritin blind, and instruct your juniors as well to give the patients appropriate management. So then you have a responsibility to report the transfusion reactions to the blood bank. So even immediately after management of the patient, please send us the reaction notification form together with the post transfusion sample and the remaining blood pack. So when you stop the transfusion and disconnect the blood pack, please do not throw it away to the dustbin. So you can return it to the blood bank for the blood pack to the blood bank in order to carry out our transfusion reaction investigation. And please send the BHT and the reaction notification form together with the post-transfusion sample. Ideally a clotted, that means a sample in the plain tube as well as an EDTA sample. So always make documentation, even if there are transfusion reactions or not. Always document what has happened at the end of the transfusion. So you can document the blood pack donation numbers, which is called TIM, and observations, volume transfused, time of commencement and completion, and if there are whether there are transfusion reactions and need, and if there is any follow-up required, please mention it in the BHT, which should go to the diagnosis card or the clinic record. So that's all. So in transfusion practice you may make mistakes, so learn from the mistakes and don't hide them, and let others to learn from those mistakes, and together we can avoid those mistakes happening in the future.
Thank you very much, Dr. Samantha Senavirathna, for that very comprehensive lecture. And we have received one question from our viewers. This is regarding positive patient identification. You know that there are two places in the PhD where the patient's name is mentioned. One is written by the admitting MO and the other by the registration at the registration desk. So what is the correct name we should consider in this situation?
So in fact that has to be decided by the hospital administrations. I have seen several letters issued regarding that. So some directors has told that the correct one is that is the name in the HRIMS, no, that in the computer system, and some directors says that we have to go by the admitting medical officer. That has to be decided by the institute. However, I think that should be one thing, that if the medical officer writes a name, it should be entered in the system, and it should be gone to the patient's records as well. If there is an error done by the admitting medical officer, we have to correct it with a signature and we can modify that. I think ideally there shouldn't be two names. I mean that should be corrected in the institutional manner.
Thank you very much for answering those questions, and thank you for joining us today for the GMO Academic Car program. Thank you, Dr. Samantha, for joining us and giving your expertise regarding blood transfusion practices. And let's meet again in 2 weeks' time. Thanks a lot, and have a good day.